and welcome. Thank you for joining us for the fourth week of our Limb-Girdle Muscular Dystrophy Virtual Learning Series. My name is Kayla White, and I'm a Community Education Specialist at MDA. We are thrilled to have you join us today for this webinar. This learning series is part of our larger MDA community education programs, which focus on bringing the neuromuscular disease community together around education and resources. Be sure to visit the community education section on mda.org for updates on upcoming events. We are recording today's event and we'll be posting it to the website for on-demand viewing at a later date. Please know that all phone lines have been muted. We will have a question and answer session at the end of the webinar, and you can use the chat feature to send in your questions, and feel free to send those in as you think of them. We'll keep a list and we'll go over everything at the end of the session. So yes, use the chat feature for those. I would also like to thank our webinar supporter, Sarepta Therapeutics. We would not be able to provide community education webinars like this if not for their generous support. We're very thankful and appreciative. For over 70 years, MDA has led the way in accelerating research, advancing care, and advocating for the support of our families. MDA's mission is to empower people living with muscular dystrophy, ALS, and related neuromuscular diseases to live longer, more independent lives. Our mission comes to life through the four pillars of care: champion, catalyst, and community. If you haven't done so already, we invite you to join the MDA community by registering with us. I would now like to introduce today's guest, genetic counselor Chelsea Chambers. Chelsea is a board-certified genetic counselor who is a graduate of the Arcadia University Genetic Counseling Program in Philadelphia. Her interests include working with patients with neuromuscular disorders. Thank you so much for being here today, Chelsea. We're so excited to have you, and take it away.
Wonderful. Thank you, Kayla, and thank you all for having me. Just give me a second and I'll share my slides. As Kayla said, I'm going to be talking today about the genetics of limb-girdle muscular dystrophy. I'm currently a genetic counselor at the University of Virginia. I have also worked at VCU, or Virginia Commonwealth University, been back and forth between the two for about the last 9 years, all in the field of neurology. So to start off, I want to go through just a little bit of basic genetics before we get into the specifics of limb-girdle, or LGMD. So genetics 101, basically what we're seeing here is we have thousands upon thousands of cells in our body, and the cells all contain chromosomes within the nucleus that's right there in the center, and the chromosomes have very, very small bundles of DNA, and this DNA is basically the building block for what makes us us. There's several genes within this DNA that create proteins, that create our musculature, our skeletal system, our cardiovascular system, our nervous system, all of our organs. Basically, anything that makes us who we are comes all from those chromosomes that are in the nucleus of all of our cells. So when I'm talking about genes, within a gene, there's also multiple different pieces. So we have the promoter region of the gene, and then what we call introns or exons. And exons are important for us to make note of because this is where most of the most of the genetic information is located that create these proteins, but those promoters and introns can also have important information. It's just harder for us to look at those when we're looking at genetic testing that we have currently available. So I bring that up just for future reference of when I'm talking about exons and introns within the gene, that it's all the two parts of the bigger gene. So for genetic disorders, what we want is that all of our genes are functioning normal, there aren't any issues with it, and then we wouldn't have any disorders or genetic disorders. Unfortunately, as we know, that's not the case though. And so what happens is there ends up being a mutated or a changed piece within that gene. And that can either cause the gene to create abnormal protein that will build up or create no protein at all. So it's the normal, and instead of having normal, it's either abnormal or none whatsoever. And I like to make the caveat, when we think of protein, we really think the protein we get in foods. But this is a different type of protein. This is more, I wish there was a better word for it, but it's basically, you want to think of the protein more of that as that building block compared to protein that is in the meat that you eat, for example. So, contrary to what a lot of people think, I like to stress that genetic disorders are common. They are much more common than we think. About 53 in 1,000 individuals will have a disease with an important genetic component before the age of 25. 70% of pediatric inpatients have an underlying disorder with a significant genetic component. 3% of the general population have intellectual disability, which we are starting to determine has a large genetic factor. 1 to 2% of US children have autism spectrum disorder, also a large genetic component. And 5 to 10% of cancer is due to an inherited genetic defect. So those are just some stats that help us see just how common in all different types of disorders, not just limb-girdle or muscle diseases, that genetic disorders are. So let's talk much more specifically about limb-girdle muscular dystrophy, or LGMD. As most of you are probably well aware, this is a diverse group of muscle disorders that have many different subtypes that are characterized by specifically the gene that causes it, as well as the inheritance pattern, whether it is autosomal dominant or autosomal recessive. Symptoms include weakness and atrophy of the proximal muscles around the hips and the shoulder, and the age and severity or speed of progression of symptoms really varies depending on the subtype, but even within the subtype, even within family members. So genetic testing, I like to stress with all of the individuals that I speak with that this isn't just a blood test, or as it's become even more common, it's not just a saliva test. This is a test that does affect many individuals other than just the one patient that physician or genetic counselor is sending testing on. It can affect the entire family. It can even predict that disease will occur before symptoms have even happened. And then there are many different issues that can vary depending on the reason for genetic testing. I've had situations specifically where I have a set of identical twins. Identical twins mean that they have the exact same genetic information. One person in this relationship wants to know if they have a genetic predisposition for a disorder like limb-girdle. The other one does not. Neither have symptoms at this time. And so that becomes a really difficult conversation, and just perfect proof of how genetic testing isn't just going to impact the one patient, it will also provide that information for the other individual. So we have some possible results that we can get. It's not always a cut or dry, yes or no, black or white scenario with genetic testing, unfortunately. So what we're all hoping for is that black or white, so a positive result, meaning yes, we have determined what is going on, that this is the genetic cause for your limb-girdle muscular dystrophy, for example, or a negative result, meaning no, you did not inherit the gene change in the family. No, we did not find any variance in any of the limb-girdle muscular dystrophy changes. So clear yes or no answer with that. However, a lot of the time we receive variants of uncertain significance with this testing. And when I say this is our fancy way of saying we're just not sure. We have a lot of information that we're looking at when we're doing this testing, and a lot of things that we haven't seen before. So the more people that we do testing on, the more information we are gathering, but it's so difficult for us to see every little change and to identify those. So these variants of uncertain significance are our way of saying we found something within one of these genes or one of these limb-girdle genes, but we don't know whether it's actually associated with the disease or whether it's just a benign change that doesn't do anything to affect the protein that's created. It's still a normal protein, or is it an abnormal protein? And then incidental findings come up much more frequently when we're doing tests that are, for example, whole exome sequencing or whole genome sequencing, when we're looking at more than just the limb-girdle muscular dystrophy genes. Then we can find specific incidental findings. Specifically, there's a list of different genes that are very actionable, cancer or cardiac implications, that when you're doing a much larger test, these types of results might come back that aren't specifically the reason for testing. So just making sure that you're aware what testing is being sent and are incidental findings something that could possibly come back for you. Now, this is one of those examples that I like to use to sort of help us understand what I mean when I'm saying a variant of unknown significance. So what you see on the left is the original. The sentence that is being said is, "I'll be by the lake." The next one over is a point mutation, a changing of only a single letter. And this one changes that E and the to a W, and it makes it so it's a little bit harder to read the sentence. Yes, you still probably get the message that this individual will be by the lake, but is it enough that someone might not be able to meet there? Second one is a different location of a point mutation. This one instead changes it to be, "I'll be by the cake." Now, this makes it much more difficult. You don't necessarily know where this individual is going to be. And so this likely would be a point mutation that would change the function of that gene and make it more disease causing. As well as these next two, the nonsense and frame shift. Like you can see from the sentences, it makes it much more difficult for us to know what that original sentence was going to be, making it that this is likely a change that will not create a normal protein or will not create us being able to find this individual by the link. So different types of genetic tests, there are several out there, as I alluded to a little bit earlier. The ones we're pretty much going to focus on are the ones that are done for limb-girdle muscular dystrophy, and that would be mutation screening or sequencing of the specific genes, or deletion duplication of the specific genes, and then that whole exome or whole genome sequencing testing that I mentioned prior. I can't give a presentation without giving a little bit of a nod to my field, specifically genetic counseling field. My job is to help explain all of this difficult information to these individuals. So our National Society of Genetic Counselors in 2006 wrote, "Genetic counseling is the process of helping people understand and adapt to the medical, psychological, and familial implications of genetic contributions to disease. This process integrates the following: interpretation of family and medical histories to assess the chance of disease occurrence or reoccurrence, education about inheritance, testing, management, prevention, resources, and research. Counseling to promote informed choices and adaptation to the risk or condition." So our goal really is to just make sure that you as patients are receiving the absolute best care and understanding exactly what your genetic risk or your family's genetic risk means to you. So now going back to limb-girdle, I stated already that There's several different types, and there's some similarities, but also some differences between the different types. So I pointed out in the next two slides what those similarities and differences are. So the inheritance pattern it is autosomal. That means that it is in every single cell of your body. It is not just in your reproductive cells of being able to pass it on. So that's why it affects multiple muscles throughout the body. The musculature is the shoulder and pelvic girdle regions for all of these, hence the name of it. The limbs normally affected are more proximal versus distal. And for labs that are generally done, the CK is typically elevated. And this is looking at basically the breakdown of the muscle. It's typically a blood test that's done early on in the diagnostic. If a biopsy is done of muscle for all limb girdles, it's typically dystrophic. And then the etiology is the muscle cell damage and muscle fiber degeneration for it. Excuse me. So for those differences, the age of onset really varies for individuals with limb girdle, as I said at the very beginning, even within families. So it can present from anywhere from early childhood to adulthood. The disease progression can be anywhere from very slow to a rapid progression. Now, as we were talking with the CK on the last slide, it really can vary substantially depending on what type. So generally is always elevated, but it can be more elevated in the autosomal recessive forms than in the dominant forms. Genes, this one is actually probably very out of date. I'll give that caveat of it, but was the information available at the time of the slide. And so there were 31 genes, and we are testing, I would say, probably close to 60 to 70 genes now associated with different types of limb girdle or mimickers of limb girdle for that. And then the possible disease mechanisms, there's several different ways that limb girdle could be occurring, whether protein aggregation, defects in the membrane repair, dissociation of the sarcomere, or errors of glycosylation of alpha dystroglycan. So I've hinted a couple times at the possible inheritance patterns for limb girdles. There are two main types of limb girdle, and it really depends on the inheritance pattern. So there's limb girdle 1, which is autosomal dominant, or limb girdle 2, which is autosomal recessive. There are some naming questions at play. A lot of the times, this is the more common one used, but some individuals are starting to move to the limb girdle D or R, and more specifically noting the dominant or recessive form. And then along with that 1 or 2 with this naming is typically a letter is assigned for each type, depending on the order of the gene of discovery. So unfortunately, there's no real easy way for us to know the specific naming other than just memorizing and knowing that this is the specific one based off of a genetic diagnosis. So for the autosomal dominant inheritance, what that means is that all of us have one gene from mom, one gene from dad. And for autosomal dominant, you only need one abnormal gene for this disease to occur. So what we see with this is dad has the condition. So he has the X, which is the non-working gene, and the check is the working. Mom does not have the condition. She has 2 working copies. So mom can only pass on the working copies of it, but dad can either pass on the check mark or the X. And so for his possibilities, there is either 50% of his children that will have the condition or will inherit that non-working gene, or 50% that will not have the condition or will inherit that normal copy, as well as mom's normal copy. So here I listed out the most common autosomal dominant types of limb-girdle based off of the specific gene mutation, what letter is associated with that. And then we have autosomal recessive inheritance. This diagram here will now show you neither of the parents are affected, but they are both carriers, meaning they both have one normal and one abnormal. And what this means is it complicates that picture a little bit more. In order for disease to occur, excuse me. In order for disease to occur, you need to have two of the non-working genes in an autosomal recessive disorder. So with both mom and dad being carriers of the disease, there's a 25% chance that their child will have both normal copies, not a carrier and not affected. There's a 50% chance that they will be a carrier, but also not affected. So they inherit one normal from one parent, one abnormal from the other parent, and then a 25% chance that they would inherit both non-working copies. So overall, two parents that are carriers have a 75% chance of having children that do not have limb-girdle, and a 25% chance of having a child that is affected with limb-girdle. And these are the different types of limb-girdle that are autosomal recessive. And there, as you can see, are a lot more recessive forms than there were of the dominant forms. So this is just a breakdown of the relative prevalence of the different types of limb-girdle subtypes. Again, this is an older, as you can see at the bottom, it's a 2013. So of course, we're learning more and more information and have learned more in the last 10 years. But I think it's the best depiction of what ones are the most common in our society. So as you can see here, the CAPN3 is the 30% of limb-girdle, or CalPain3, which is type 2A. And then it breaks down. We've got the green over here. I believe, yep, that's the DYSF or dysferlin. Here as the 19%. FKRP is here, and that's our 18%, but then it drops significantly for most of the rest. So large breakdown with only a few at the top, but specifically the most common ones that we have are listed here, with some of them likely to present in childhood, as well as some of them that have a cardiac involvement that is common with that. So the importance of genetic testing. Hopefully I've already encouraged you all that it's important to have genetic testing to determine the specific type of limb-girdle and the type of inheritance pattern. But other reasons is for accurate diagnosis and treatment, to really help end that diagnostic odyssey. I understand I have seen so many patients that are frustrated because they don't know why. Why do I have these symptoms? What is causing it? And this helps them to have an answer for that. As well as it can help avoid inappropriate treatments that may not work, and is more efficient use of resources for these patients. Management and surveillance of affected individuals is more accurate when we have a genetic diagnosis. And I'll talk more about that on my next slide. It can also identify pre-symptomatic individuals, as I talked about at the very beginning. Individuals that may not have symptoms yet, but are interested to know whether they're at risk for developing them in the coming years. Also can help to have that discussion of reproductive risks to couples at risks. What is their chance of having a child also affected? And what are those options that they're faced with? And it does open up research opportunities for individuals as well. That's the exciting point that we're at right now, that there is a lot of research going on for our limb-girdle muscular dystrophy population. So specifically for management, although there are some similarities between the subtypes, as we learn more about the disorders, we're learning more about the differences between the subtypes. So the phenotypic presentation can be different depending on the subtype, or the type of symptoms could be different depending on the subtype. And this could change management and include referrals to other providers. Is this an individual that needs to see cardiology because there's known cardiac implications? Or do we need to make sure that they're seeing respiratory because of that known involvement? And making sure that we're getting you connected with the right resources, so that we can provide the very best care depending on the subtype. Unfortunately, there's no current definitive treatment for limb girdles. Management is very tailored to each individual and each specific subtype, to help improve the quality of life, really more managing the symptoms, and trying to help with what those are, based off of the fact that it would be beneficial for you to follow with multiple individuals. It is typically recommended that you be followed by a multidisciplinary team, and they can provide assistive devices and appropriate therapy and exercise, as well as management of those specific symptoms. Now, research. As I said, it's a very exciting time in muscular dystrophy for research right now. There are many studies that are specific to genetic causes of patients' limb girdle going on. Best way for you to determine if you're eligible is to discuss it with your physician, as well as MDA has a clinical trial finder, and clinicaltrials.gov is a great resource. So those are ways for you to get connected. And then to wrap up, I just wanted to go through a couple cases of individuals that I've seen in clinic. Here, what you'll see, we've got females are circles, males are squares, and the pluses and minuses are those individuals that have had testing. So what you'll see is here, this individual with the arrow pointing to it, the green female, has had testing and confirmed limb girdle type 1B, was able to have testing for other family members, but there's a strong family history of myopathy even before testing was done. So that female presented, 49-year-old female, presented with weakness in legs when climbing stairs, getting up from a sitting position in her early 20s. Had weakness in upper extremities, later developing. Her CK was about 202, so not super high, but high enough. And EMG was suggestive of chronic myopathic process, and muscle biopsy showed non-inflammatory myopathy with no abnormal staining. Genetic testing was sent back in 2016 and did find a variant in the LMNA gene, as I noted on the pedigree, and that's associated with the autosomal dominant limb girdle type 1B. And this specific disorder typically presents with that hip girdle muscle weakness before 20, slowly progressing to the shoulder girdle muscle weakness, which was classic for her presentation. And other symptoms might include joint contractures and cardiac symptoms. So this patient was referred to cardiology. For the second case I have here, I apologize, everyone. Getting over a cold. For this second case here, it's a female that presented at 19 who's experiencing leg weakness. Oh, excuse me. There we go. Experiencing leg weakness since about the age of 13. Difficult for her to jump like other children, difficulty climbing stairs, getting up from a sitting or lying position, and difficulty running. She reports gradual progression of symptoms over the past few years. Muscle biopsy in 2013 showed consistent findings of muscular dystrophy, and dystrophin 1 and caveolin 3 stains had intact member staining and some cytoplasmic staining. So basically what it's saying there is just that the muscle biopsy was normal for staining. So genetic testing was sent in 2015 and did identify 2 variants in the CAPN3 gene, and 1 pathogenic variant and 1 variant of unknown significance. So there's back to that gray area type results. So this specific gene is associated with limb-girdle type 2A. It is the most common form of limb-girdle and normally does not have cardiac involvement. And the pedigree that I showed back here is very typical. We'd expect that mom and dad must have been both carriers, and she just was that 25% that got the abnormal copy. So we were able to eventually reclassify this variant of unknown significance. We did some parental testing, and as time went on, and it was found in more patients as well, both of these variants ended up being pathogenic. So it was a clear diagnosis for her. But it was one that we had to go through. We couldn't just see this 1 pathogenic and 1 variant of unknown significance and say, yep, that's what the answer is. We had to go those extra steps in case that second one was benign and this wasn't actually the cause for her. And then the last case before we get to some questions is this individual here. Again, the male in red, 59. And he presented with progressive proximal more than distal weakness in 2004. Had scapular winging and a muscle biopsy that showed myopathy, and did have some different staining on that muscle biopsy. Did some genetic testing, a specific panel in 2015 that included 40 genes, and it came back with 2 variants of unknown significance. Unfortunately, neither of these were explanations for his disease based on symptoms. And unfortunately, even with genetic testing, hopefully this patient has been back to see someone else to have testing redone. But I have not personally seen this patient since about 2016. And so they did not have a clinical diagnosis, or they had a clinical diagnosis of limb-girdle, but they did not have a genetic cause identified. So unfortunately, they were still left in that little bit of diagnostic odyssey realm, which I know is a very unfortunate and frustrating spot for our patients. And I do have several that fit that. But I give this caveat with, it's important to continue to come back. That testing that we did in 2015, we have included so many more genes that we would do at this point than what we did in 2015. So if he were to come back to clinic, we would have additional testing, and hopefully that additional testing might find an answer for him. So with all of that said, I'd love to open up the floor and take any questions that people might have.
Thank you so much for sharing that. We have had several questions come in. So let's see. said was, wouldn't some patients have a mutation that causes a reduction in the correct protein being made? And those patients would likely have a milder version of the disease.
So it really depends on what type of disorder we're talking about. And we're not sure. There's a lot of questions out there on if there might be something in the promoter region that is decreasing the expression of the genetic information. And so the disease is not as severe, and that's why it's milder. Those are great thoughts, but there's nothing we have definitively said, yes, this is why.
Gotcha. All right, next question is, both of my parents are gone and can find no one on either side who has muscle weakness history. Would genetic testing work for me?
Yes, even without having parents available, we're testing your genetic information at this time, and we might be able to figure out that it is just known disease causing testing for you, known disease causing variant found for you, and then we wouldn't have to look any further on either side of the family. Definitely recommend talking to your physician about doing testing.
All right. Let's see. I have LGMD2L. Is it possible to pass on LGMD to my children?
It is. It is less common just because your partner would also have to be a carrier. So limb-girdle 2L is an autosomal recessive. So you have both non-working copies. And so you can only pass on one abnormal copy. But then if your partner were to be a carrier, so they have one normal and one abnormal, there'd be a 50% chance of them passing it on. But if your partner were to be unaffected completely, did carrier testing, they were not even a carrier, then it would be all of your children would be carriers, but no one would be affected. There would just be risk for future generations if they were carriers.
Okay. Somebody has asked, I have LGMD and my daughter's normal and now have 3 grandchildren and all are healthy. My sister has 3 children as well, and her grandchildren are all healthy as well. Would that be a good sign? Originally, I was told 50% chance of passing, so we only had 1 child.
Sorry, what was the type that she had?
Just as limb-girdle.
Just limb-girdle. Okay. So I would say it's reassuring that they don't have symptoms, but we can never completely rule it out without genetic testing. So it might just be that your daughter hasn't presented with any symptoms, or it could be that it's autosomal recessive, and so she would be a carrier, and then there'd be risk for her children potentially if her partner were to be also a carrier. There's a lot of different possibilities, especially if you don't know your specific type. But reassuring that they don't have symptoms just doesn't completely rule it out.
Somebody has asked if you could please explain autosomal recessive one more time. Does this mean the gene mutation did not come from either parent?
It means it came from both. So the way I like to think about it is if we have, if we have one line and one X, that is what's happening with each side. And so for the disease to occur, both have to pass on the X, and it only happens 25% of the time, because 25% of the time they'll pass on the line, and so they will be completely normal. Or dad will pass on the line, mom will pass on the X, or dad will pass on the X, mom will pass on the line. And that means those are carriers, but they are not affected. They have risk for future generations, but not for themselves. So that is where the 25% risk comes in. I hope that's helpful. It's so much harder to explain virtual.
It is helpful. Thank you. So a question that had actually come in earlier, somebody wondered how can they prepare for a genetic counseling, genetic testing visit?
That's a great question. The more information that you can gather on your family, has anyone else had genetic testing? Has anyone else had similar symptoms? What type of symptoms were they? And just gathering that type of family information, especially if there's genetic testing. If you can have that report in hand when you go in, that makes things a lot easier to figure out. We can do the investigative work and we can try and find that. But a lot of the times it's harder for us to get those reports since that family member isn't a patient of ours.
One question that came in actually has to do with cardiac issues. And so actually want to mention that next week, week 5, the last week of our LGMD series, we will have someone who is here to talk about cardiac issues. But is there anything, somebody had asked which LGMD diagnoses have cardiac issues?
Yeah, it's a list of them, and honestly, I don't know off the top of my head, but yes, that would be the person to talk to next week. Hopefully answers all those questions for you.
It's probably too long of a list to know off the top of your head. I completely understand.
Yes.
Somebody has asked, my CK is always in the 9 to 15,000 range, a few times in the 20,000 range after a fall and spraining both ankles. Is there a range that is a cause of concern?
I would say that's a better question for your physician. It isn't shocking that after injuries, it's higher. That is just even for marathon runners, we'll see that their CK is very increased after they run a race, just because there is so much muscle breaking down. But specifically those numbers and where the line is on whether you should be concerned would be something I'd ask your physician.
All right. If you had genetic testing done in around 2010 and got a genetic diagnosis of LGMD2D, is there any reason to retest now to be able to learn more with likely more sensitive testing available today?
That's a great question, especially with all the caveats that I gave. No, if you had pathogenic variants identified, now if you read your report and it says variants of unknown significance, yes. But if they are clear disease-causing variants on that report, then that is an accurate diagnosis for you. You just were one of the ones that had one of the most common gene changes found. So there might be additional information on the care of patients if you haven't seen someone in a while, but I wouldn't recommend doing additional testing if you have that diagnosis already.
Okay, this is a question that had come in previously as well. What are some of the limitations to genetic counseling and how accurate is it?
Yeah, genetic counseling is more what I am having a discussion similar to this for you. The genetic testing limitations can be vast. There's a lot that we don't know. And honestly, that is one of the hardest parts of my job is that most of the time I am not giving an answer. Most of the time I am just helping you walk through the process and understand all of the gray areas of this and all that we don't understand. The accuracy though of did you get a positive result, as I answered for the previous question, that I would believe, but a negative result, I recommend checking back with physicians every 2 to 3 years. If you've had negative testing, there's a lot that changes. And I'm retesting patients and finding answers for them that I saw 5 years ago that are now that we didn't find anything, but we're now finding something.
Somebody has asked, how can I find out what type I have?
Seeing your physician, getting connected with a genetic counselor. If you're located in Virginia, hit me up. But basically talking with them and getting genetic testing done is really the only way to figure out your specific type.
Okay. Somebody was curious if there are any disadvantages to going through this process.
That's a great question. So the caveat I will give is with our current state of everything, no if you have symptoms already. If you have symptoms already, this is just trying to figure out a reason for your diagnosis. If you do not have symptoms and you are just a family member that knows they could be at risk, then that falls into your predictive or pre-symptomatic testing. And that could, with GINA, it's a law in place, and that it protects for employment and medical insurance, but does not protect for anything else based off of genetic results. So genetic results could be used against you for life insurance, long-term care insurances, any of those basically elective insurances. So if you have symptoms, no, you already have that pre-existing condition. But if you don't have symptoms, then yes, that's an important thing to talk to your genetic counselor about prior to proceeding with testing.
I didn't know that. Thank you for sharing that. That's very important information to know.
Yes.
Somebody has asked, I have a child with heterozygous LGMD2I. Would it be possible to have another child with LGMD2I?
So that, yes, that is, I'm assuming you mean heterozygous, meaning there are two mutations found. They're not just carriers. If they're affected with 2I, that means most likely with the same parents, mom and dad are carriers. And so it would be that 25% risk again, if it is the same partner. And so it is that flip of the coin with each pregnancy. So 75% of no, 25% yes. But yes, there is a possibility. Unfortunately, we see everything with these autosomal recessive disorders where they'll have 4 kids and all 4 kids will be affected, or it'll break down to 3 and 1, or it'll be none are affected. It just is the luck of the draw, unfortunately.
Someone has asked if you can speak to one parent having both recessive genes. A genetic counselor at Emory said this was possible.
Without being both parents having it, without being, I guess I'd need a clarifying, without being affected.
We'll wait and see if that comes in.
Okay.
Because that's all the question said.
Okay.
So while we're waiting on that one, somebody has asked, my mom was diagnosed with myopathy and lived majority of her adult life in a wheelchair. She died of cancer before I was diagnosed. My dad had a genetic test when I had one done. He is not a carrier for a mutated gene. I was diagnosed with LGMD2B. Is this usually a common occurrence?
Sorry, could you go through the situation again?
That was a lot, yes. So my mom was diagnosed with myopathy and was in a wheelchair. She died of cancer. Dad had a genetic test, is not a carrier for a mutated gene, but this person is diagnosed with LGMD2B.
So unfortunately, yes. The likelihood, 2B as well. So there might have been something else going on with your mom then, since it's recessive. But yes, then it could be either misattributed paternity is the most likely. So unfortunately, dad being not dad, could be the situation. Or it just could be that they weren't the lab, if testing was done at different labs and one lab couldn't detect that mutation properly. Or it could be that there's a new change that popped up coming from dad and the other one came from mom. I would say that those are probably the 3 most likely situations for that.
Okay, so we have 2 clarifications to go back to. So about the LGMD2I, just to clarify, this person was asking if one kid is heterozygous, can another child be diagnosed with homozygous?
Yes.
Sorry, that was my fault. I didn't get all that question in there when I was making my list.
No worries. So what that means is that child is a carrier for it. What I would recommend is that mom and dad both be tested And if only one parent is a carrier, then the likelihood is low that you would have a child that is homozygous for it. But as the last question very clearly pointed out for us, there is always that possibility of it even occurring, but it is a much less likely if it's only one parent that is a carrier.
Gotcha. See, it helps when I give you the full question instead of missing a part of it. So also going back to the question of, can you speak to one parent having both recessive genes? Neither parent affected, nor are brother and his kids and grandchildren affected.
That is an interesting situation, and honestly, I would have to see the test report to really comment on it.
Sometimes we can't get an answer. Sometimes it's so specific that it's hard
As
to.
I said, I work in uncertainty a lot, so
yes.
reading a report and reading the report helps me to piece it together a little bit more sometimes.
Gotcha. I'm looking through the chat. I don't see any. I don't think I've missed any questions. I don't see any more coming in. Let me just check. Let's see. Somebody did put some genetic testing results in the chat that are way above my head. But this is the person that was asking about the both parents having one parent having both recessive genes. So I don't know if you can see the chat or not.
I can. So yes, this is a great part that I did not even touch on, is that there can be multiple mutations in even the same gene. So we have one from mom, one from dad. Typically, if it was a very easy situation, there's only one mutation present. What sometimes we find is that there can be multiple mutations in the gene. Would make us think that that likely makes it definitely doesn't work, but the other one does. And so that is a situation where it's that parent is still a carrier as long as they're both on that same one gene. And so typically you need to have parental testing done or other family member testing done to see if it's tracking along the same or if it is truly on two separate ones. And then this could just be a situation of no symptoms yet. But the likelihood would be in that situation that the parent has it in one of their genes and their other gene is normal.
Gotcha. Somebody has asked, how often do you test grandchildren as part of your family genetic testing?
That's a great question because it can really depend on the type and parents. So most of these are later onset, but there can be childhood onset for it. And that's why we do testing in children as well. But it comes down to, does the parent want testing done? Does the child agree to be tested? And that comes down to having a very long discussion of, do they want this kind of information right now if they don't have symptoms yet?
All right.
Oh, go ahead.
Go ahead. No, go ahead.
Yeah, if they do have symptoms, of course, that conversation becomes a lot less. We're just trying to figure out why they have it. If they don't have symptoms, it's much more of a discussion.
Gotcha. That makes sense. Somebody has asked if there's a full genome sequencing company that is better than the rest that you would recommend.
I would recommend not doing any of the direct-to-consumer ones. There's a lot out there. I would recommend going through a physician. With that said, there are a couple that are better on the market than others, but I have not personally experienced that yet because I have not done needed to do a whole genome on a muscular dystrophy patient yet. We've been able to find answers before doing that, or it wouldn't provide much more than what we did ultimately. So I don't have any I would specifically recommend, but I would recommend talk to your physician.
A couple questions just came in. Do insurance companies pick up the cost for testing?
They are becoming much better about it, especially with a family history of it or symptoms yourself. They are covering it much more readily. There is also a lot of free or sponsored testing out there that's available for those that aren't. Caveat to that, genome is still one of those that is not getting as covered as readily because it is so newer on the market. And so that's why we haven't done as much genome, myself at least.
All right, so we are coming up on the end of our time. So I've got one more question that came in. I don't know if you can read along in the chat, because it's a longer question, but somebody's asked, what is your process for reclassifying mutations as to pathogenic or variant of unknown significance? I have a dominant version. Confirms symptoms are limb-girdle muscular dystrophy 4D, but it's not been reclassified. How many client studies do you need?
So for reclassification, I have so many patients that I see, there typically is not a reclassification. I'm not looking for that unless the patient comes back. So I recommend with all my patients, if you have variants of unknown significance, contact me every year when you're having your checkup with your neurologist. And that way I'm reminded to look and see, are there any new information available for that variant? Now, with that said, there are some labs that do send out updated information as they reclassify it, but that is not the common practice of all of the labs. So it really depends on where you were tested. Now, with that said, on how many client studies do you need, really what it comes down to is enough different individuals with other supporting information. So for example, in the labs, if they're able to do information on a research basis and find specific things to say, yes, this is disease causing, that helps as well as finding other individuals with it. But there's a lot more work being done. I'd say that if your testing wasn't done in the last year, check in with whoever did it to see if there has been a reclassification on it, and continue to check back even if that answer is no right now.
Perfect. I actually think we got through almost all of the questions. So since we are running out of time, we're going to have to start wrapping things up. So Chelsea, thank you so much again for sharing all of your time and your expertise with us. We just so appreciate everything you do for the neuromuscular community, and we're so happy to have had you here with us today.
Thank you.
I would like to again thank our webinar supporters, Sarepta Therapeutics. We would not be able to provide community education webinars like this if not for their generous support, so we thank them very much. If you are new to MDA and are diagnosed with a neuromuscular disease under MDA's umbrella or are a loved one of someone who's diagnosed, we encourage you to stay engaged with MDA. You can do this by visiting mda.org/join and completing a short form. Joining is free and will keep you up to date on the latest research, educational programs, and supports. We would love to hear your comments about this webinar. If you have a smartphone, you can open your camera and point it at the QR code on the screen, which will pop up a webpage with a short survey on the webinar. If you don't have a smartphone, once the webinar is over, a screen will pop up with a survey as well, and you'll also get it in an email. If anyone has questions after this webinar, please feel free to email them to mdaengage@mdausa.org, and we will follow up with you. This concludes the 4th week of the LGMD Learning Series. Thank you so much for attending. We hope to see you next week. It's our last week of the series, week 5, where we'll be talking about cardiac and heart health. So we hope to see you then. Thank you all.